Morning, everyone. So I'm going to have the residents go ahead and I'm going to give you guys the ability to talk because I'm going to do a couple SANS questions, and then we'll move on to spine conference second.
Hello?
Welcome, everyone. So we'll go ahead and get started with a couple SANS questions. This first one is a 7-year-old boy with GMFCS grade 5 spasticity and a baclofen pump who presents to the emergency department with a 40-degree fever, severe spasticity and agitation. What is the next step in management? So we'll go ahead and get started with Matt Carr. Take me through your thought process and what you think the correct answer to the question is.
Hi, Dr. Morgenstern. So reading this question, I think that it's possible that baclofen pump is malfunctioning and the patient's going through withdrawal. So I'd want to first treat his withdrawal through IV baclofen, answer C.
Perfect. Why wouldn't you want to do any of the other things?
Well, I'd want to stabilize.
A better question is, why are each of the other answers on the list? Because on the boards, you're going to get a bunch of answers that look like they make sense, but they make sense for different questions.
So I think answer choice A, lumbar puncture, is there to make you think about possible meningitis and wanting to, work that up.
Mm-hmm.
Same with blood cultures. It's probably there to make you think about sepsis or some sort of infectious process. And then D and E want you to jump to the surgical management, but I think stabilizing the patient first with IV baclofen is more important.
That's exactly right. So this is a question that will probably pop up on the board somewhere, basically every year. So if you can recognize it, you have one free point. All right, we'll move on to the next one since you crushed that one so easily. Why don't we move on to Halima? An 8-year-old boy who presents with diplopia, headache, and the MRI finding below. Biopsy demonstrates a pineoblastoma. Which of the following best describes his planned following treatment course? So do the same thing that Matt did. Dissect the question. Give us the reason for the other answers.
So starting with A, actually I'll just, so radiotherapy alone. Please neoadjuvant, chemo, surgical resection. So I think it should be C, surgical resection with adjuvant chemotherapy. With the thought process being that I would surgically debulk the lesion and then do the adjuvant chemotherapy. I wouldn't do radiotherapy alone.
Right. Well, you're right about surgical. You're right about surgical resection. But Ray, what is the correct adjuvant treatment for pineoblastoma? So Halima narrowed it down to C, D, and E for us.
Yeah, I think this needs both chemotherapy and craniospinal radiotherapy.
That's right. Why is that?
These are very high-grade tumors that tend to disseminate in the CSF.
Perfect. So to continue in that vein, which of the tumors that can occur in the pineal region is treated by radiotherapy alone more commonly? There's only one.
Oh, germinoma?
Yeah, good. And then for B, neoadjuvant chemo, surgical resection, and adjuvant radiotherapy would be an acceptable treatment pathway for which tumors? Related to germinoma, but not exactly.
Like yolk sac tumors and choriocarcinomas?
Right. So on that, they all fall under the category. What are those tumors called?
Germ cell tumors.
Right. Non-germinomatous germ cell tumors, because germinoma is also a germ cell tumor, but the non-germinomatous germ cell tumors are commonly treated with this pathway nowadays, although not 100% of the time. I don't think surgical resection and adjuvant chemo is used for any of the pineal region tumors as sort of a first line, unless there's a reason that you can't give radiation therapy. So in children under 3, you might give high dose chemotherapy instead of radiating them because of the negative effects of radiation in a young child. And then surgical resection and adjuvant chemo with focal radiotherapy might be for a lower grade tumor where you don't need to give craniospinal radiation. Good. Okay. So with that, we'll move on to our spine day today. We're going to start with spine conference, and then Dr. Chowdhury is going to speak at about 7:45 to give us an introduction of our Kubi lecture and some remarks about our visiting speaker. And then we have Dr. Theodore, who will be presenting the Kubi lecture. And we're all looking forward to his presentation. So with that, I'll give the floor to Travis to lead spine conference.
Morning, everyone. I'm just going to share my screen in a second. Hold on.
Travis, I'm going to make all the residents panelists so that we can see their video and they can speak during spine conference if you want to ask any questions.
Yeah, that'd be great. Let me see if I can get my video up. Dr. Morgenstern, can you just confirm? Can you see my screen?
Yeah, I can see your screen and your video. And for the residents, as I'm making you panelists, please mute yourselves.
Okay, great. So let me get it loaded up. So to start spine conference, we'll just present a case. This will be for Matt Carr. This is a 63-year-old gentleman, no real significant past medical history, some hypertension, some diabetes that's pretty well controlled in BPH, that is referred to you because the patient complains of progressive weakness and numbness in his lower extremities, and also noted new urinary incontinence. You get an exam on this patient, and in his upper extremities, he's intact. His lower extremities, he does have weakness, about 2 out of 5, not anti-gravity. He has a sensory level at T6. His reflexes are borderline, mainly normal, and he comes to you with a Foley. So Matt Carr, what do you think is going on in this patient, and what do you form in your differential diagnosis for this patient?
So I'm pretty concerned this patient could have thoracic cord compression. So the differential I think here is pretty broad still. I would be, it could be something compressive from degeneration. He is 63 and it is progressive. It could be neoplastic, some sort of thoracic tumor, or it could be, possibly a vascular lesion as well in the thoracic level, some sort of venous malformation, fistula, something along those lines. It could be an infectious process. He has diabetes, slightly raising his chance of an infectious process. So I'd want to rule that out as well.
David? I think that's a great differential for the kinds of cases that'll be sent to you as a spine surgeon. Could you go more into infectious etiologies that you might think about?
So there could be a, spinal epidural abscess, something like TB, I'd want to keep in the back of my mind, although nothing we've prevented with so far makes this patient necessarily at risk for something like TB. It could be helpful too, if he has infarct areas on the left side.
Yeah, that's great. Other things I would throw out are, could this be like a atypical Guillain-Barré? And could it be an inflammatory process, such as like a transverse myelitis or atypical multiple sclerosis or some such? these are the kinds of things that the oral boards might throw at you, and to kind of mislead you. So anyway, excellent differential diagnosis, Matt. What do you want to do next to work this patient up?
I think we definitely need some spinal imaging. I would actually probably want to go straight to MRI given the severity of his symptoms.
Okay, so you do that, and we have a couple of key pictures to review. So if you take a minute, look at it and tell us what you think.
So here we have T2 MRI, sagittal and axial. In the mid-thoracic region of the cord, there appear to be a lot of hypointensities. I mean, looking at them, they sort of look like vascular congestion. I mean, I don't know how to better describe it than that. But this definitely raises my suspicion that there is a vascular process going on in the thoracic cord.
I think you're right. So we call those flow voids, that kind of tangle of vessels and that you see there in the sagittal. Can you tell on this scan if that is an intradural process, extradural process, intramedullary process? Is that clear to you?
It looks pretty intramedullary based on the axials. I mean, the flow voids are sort of right in the middle of the cord.
It's hard to tell based on the imaging I gave you, but I think it's extramedullary, but within the dura, intradural. And what do you think of the cord itself? Does it look unusual to you?
Yeah, I think there's some, cord signal change. The cord distally looks a little hypo-intense.
Yeah, looks like a central hyper intensity in the cord that makes you think it's like edema, right? And does the cord itself look normal in caliber to you?
No, it looks a little thinner in caliber.
Yeah, looks a little thinned out, like this might be a process that's been going on for a while. And then on the far right sagittal, do you see that neural foramen? Does that look normal to you?
No, I mean, it does not look normal. I mean, it looks like there's something.
Looks like there's something there, right?
Sort of, yeah.
Okay. What does this patient need next, Matt?
I think this patient probably needs a catheter spinal angiogram.
I think that's excellent. So good. I'll show you that in a second. Here's a question for Halima. Are you there, Halima?
Yes.
What is foie à la Jouanine syndrome?
I don't know.
Okay, I won't torture you with more eponyms right now. So this is a described condition of the progressive myelopathy that you see specifically from vascular malformations of the spinal cord. And it comes from venous hypertension. So you have a lot of this arterial flow into like a nerve root or into the draining veins of the spinal cord, and it causes the type of cord edema that we had seen on that patient's MRI. And the classic description of it, though there's variants, is that patients start with spastic paresis or paraplegia that progress to flaccid. They have an ascending sensory loss from the level, and then they're incontinent. So kind of what this patient had. So if you could ask this on the boards, that's what it is. And just to bring us home, Matt Carr, we do the angiogram that you had requested, and this is what we see when we get to the T5 level. Anything going on there?
I see a lot of like tortuous vasculature. They just filling
The
in the
tortuous
venous phase.
vasculature is
Uh,
that
in-
arterial, capillary, or venous, Halima?
It seems to be filling in the venous phase more than the arterial.
Does it look delayed, or does it look early?
It looks delayed.
I don't know. You still see the arterial phase washing out as this vein starts. So to me, it looks like an early
Early?
vein that is originating like a level below the T5 pedicle, like a fistulous point with congested early veins. So I think that cinches Matt's diagnosis for this patient. Also, something I didn't tell you, if you look at, this is you're subtracted, but do you see this stuff here?
Mhm.
What could that be, Halima? Okay, it's actually an onyx cast from a prior embolization this patient had from an outside hospital. So this patient still has symptoms, getting worse, has an incompletely cured fistula. So that's why they referred here. And now for our SANS question of the day for spine conference. This one will go to Abhi. Abhi, are you on the line?
Yes.
Okay. So you talk to your patient and he asks you, which of my symptoms are gonna most likely to get better. So these options that you have, which symptom from his fistula is most likely to improve after resection or treatment of this lesion?
I'd say like neuropathic pain,
You want to try again?
motor.
Yeah, motor. So these are lesions that cause venous hypertension. In terms of motor, most patients after treatment will have stabilization or even improvement, and the motor is most likely to improve. The one that's least likely to improve is incontinence. So you have to prepare the patient for that possibility that might not get 100% better. So I wanted to introduce this case as a jumping off point to describe the vascular anatomy of the spine and the spinal cord. And then we can talk more about malformations later, but I just wanted to give a kind of a broad overview and then a couple of specifics about how the spinal cord, dura, bones are supplied, and how we think about that in surgery, both from endovascular and open considerations. So the blood supply to the spinal cord is basically intimately linked to how the aorta is arranged. So to look at thoracic, every intercostal level from about T3 down, you have arteries that are going around and anastomosing with anterior spinal artery and posterior spinal artery. It's a little bit different in the neck because it's above the arch. So, and I'll go through this, but a lot of it's from collateral pathways, from neck vessels, and from the vertebral artery. And then the lumbar spine is similar, has its own branches that come off medial sacral and some of the vessels from iliacs. the general organization of the vascular anatomy of the spinal cord is that anteriorly, the anterior spinal artery feeds everything, but then it's reinforced by all these anastomotic branches that come through transversely. So the kind of a cartoon picture of this is you have a bunch of vertically, longitudinally oriented arteries supplying cord, and at each level you're giving off some more supply. The same thing happens posteriorly with the posterior spinal arteries with reinforcements and anastomoses from other levels. And we'll look at those more specifically next couple slides. So this is of the neck. I'm showing you the subclavian arteries coming off, one on the right, one on the left. Carotids and then vertebral arteries are usually one of the first branches that come off subclavian. And then there's two major trunks that come off more distally. So do I have Ray Feng on the line?
Yeah.
Ray, could you please identify this first trunk that comes off that is more medial and anterior on the subclavian?
Medial.
Right here.
Vert. Like, your mouse is gone.
My mouse is gone. That's weird. Yeah. All right. So here's vert.
Uh-huh.
What about this one?
This one is
Where's it going to?
it's going to, oh, thyroid?
Okay. Yeah. Thyrocervical trunk.
Okay.
So it gives off a couple important branches we'll go through. One of them being the inferior thyroid.
Mm-hmm.
If that's thyrocervical trunk, then what is more distal, coming off the back and going down, or going around like ribs and going up neck? This branch here.
Suprascapular?
Not suprascapular.
Intercostal?
Okay. Costocervical trunk. So the
Okay.
reason those two are important is they give off collateral blood supply to the bones, muscles of the neck, but also they anastomose with vert and supply the nerve roots and dura through these collateral pathways. And when we're thinking about looking for fistulas in the neck, or if we're looking at tumors that we potentially could embolize, understand the blood flow, these are often important vessels to see if there's any early venous drainage, or to see if there is a good pedicle to embolize a tumor. And the major accessory branches that we think about are one, the starting at the thyrocervical is ascending cervical artery, which is this one that's pointed out here.
Mm-hmm.
The deep cervical artery, which is this one's here coming more posterior laterally. And then the supreme intercostal artery. So the supreme intercostal artery is important to think about because it's the one that supplies the intercostals, the first couple levels of the thoracic ribs. Because as you can imagine, the aortic arch there's still like thoracic spine above the aortic arch, and somehow you've got to get blood supply there. So it's actually coming from these higher up neck vessels. So to do a complete spinal angiogram, you often have to get that vessel to rule in or rule out a fistula. And then the other vessels we'll look at. So we can ask, is Jock Lara on the line?
Yeah, I'm here.
So Jock, this is vertebral artery
Hello?
seen in a reconstructed CT angiogram. Could you please tell us about the segments of the vertebral artery from the origin of the subclavian up to the skull base? How many segments are there, Jock?
There's 4 segments of vertebral. 4.
Okay.
There's 4 segments. The first one is the right after the subclavian. Then there's the cervical portion itself is V2. V3 is the flexion that the vertebral artery do backward in the arch of the C1, and V4 is the intradural segment.
I think that was excellent. Can you, with regards to V2, can you be more specific than just cervical? Where is the vert traveling, and why is that different than the V1 segment?
Sorry, I can't hear you. Say it again, I can hear you.
You want me to repeat? With regard to V2, how is that anatomically different than V1? Where is it traveling?
It's in the vertebral foramen, the lateral. Sorry, in the
Okay, that's great. Nice job, Jock. And then some other variants of the vertebral artery that we think about are, is it a dominant left vert, a dominant right vert, is there codominance? Usually the left is dominant. Occasionally they both share dominance, and that is important if you have to sacrifice vertebral artery, if you're concerned that you're still perfusing anterior spinal artery, or if you're perfusing the posterior brain circulation. And then as you point out, Jock, the vert enters usually at C6 foramen, but sometimes it can enter at C7, and you got to think about that as a consideration when you're doing surgeries. Where is the vert? Is the vert entering at C7, C6? Is this is this safe or this not safe? So you can look at the foramen itself on a non-con CT, or you can, if you have vessel imaging, even better to appreciate. Okay, so that's vert pictures. I just wanted to show that this is a lateral angiogram showing the vert. It has a lot of collateral and muscular pathways. So even as a vertebral injection, you can see it on this lateral at C2, it's still like supplying a lot of muscle, spinous process, lamina, and it's even, I don't have an AP to show you, it's even supplying the radicular arteries going into nerve root and into cord. And then just to briefly go through, is it like acidic cervical? This is a branch of the thyrocervical trunk. It's running in the prevertebral fascia. It's mainly in the anterior lateral part of the neck. It gives a lot of spinal branches to the cord and to the muscle. This is an angiogram I found online, but it shows from a direct injection of icing cervical that you get filling of the anterior spinal artery via collateral pathways. So important artery. And if you have vert occlusions like chronic, it may be a means to keep perfusion of the spinal cord, even in the absence of a vert. Deep cervical, similar. This one is more posterior lateral and more of like the spinous processes, neck muscles in the back, and also has vert and anastomoses. And this one too, selective injection of deep cervical, it's giving off branches to the vertebral body. It's giving off branches to anterior spinal artery directly. And this is a nice Netter's picture showing the posterior aspect of cord. And I never knew until I was preparing this talk, like never thought, where does this posterior spinal artery originate from? It just appears, because we all hear, you know, the anterior spinal artery comes from the vert. So I'll throw this one to Halima. Halima, where does posterior spinal artery originate from?
From pica.
From pica, also vert, as is demonstrated in this picture. So the intradural part of the vert gives off two paired posterior spinal arteries. And then coming in from lateral to medial, the vert and the ascending ascending cervical, deep cervical are giving off these transverse collateral branches that are feeding nerve root and anastomosing with posterior spinal artery. So very important. This is just a cartoon to show the segmental arrangement in the more of the thoracic spine as we're moving down. So the thoracic aorta is going interior to the vertebral body. You get these posterior intercostal arteries that come off, and then they give branches around the level of the neural foramen that one go up, out into bone, into muscle. The ones you always get bleeding from when you're doing transverse thoracic spine approaches. But also you get these very important collateral branches that go into the nerve entry area. So you get an anterior branch, a posterior branch, and we'll go over this in the case of the lower thoracic spine. There's a very important artery called Adamkowitz that supplies a majority of this collateral network of supply to the anterior spinal artery. I have a couple more pictures. This is axial section showing the same thing. Intercostal artery coming out, giving up a posterior branch that is going into following the dura of the nerve, going and supplying anteriorly, posteriorly. Very important supply. This is another picture. This is more lumbar spine. Nothing more specific to add, but that we didn't see on the other ones. I just thought it looked nice. And then we get to the nitty gritty of how the spinal cord itself is perfused. Again, you have these segmental arteries that give off posterior and anterior branches that will go up and around, supplying dura, anastomosing with posterior spinal artery posteriorly, supplying anterior spinal artery anteriorly, feeding the nerve roots. And I'll show this in a couple pictures. There's also a very rich network of collaterals from posterior to anterior spinal artery called the arterial vasocorona that ensure that there's complete circumferential perfusion of the spinal cord. This is a better way of representing that. So this is cross section. This is anterior. This is posterior. Anterior spinal artery running here in this median sulcus. This is posterior spinal artery, posterior and laterally, and then the vasocorona supplying all the cord with collateral pathways, and then the anterior spinal artery is getting fed by all these anterior transverse collaterals, and the posterior spinal is getting fed by all these posterior collaterals. And this is a nice Netter's drawing to show this again. I also wondered where's the dura of the spinal cord getting its blood supply, and it's getting it from all these transverse branches that as they enter the foramen, they go up and around. They feed bone, they feed the dura, both anteriorly and posteriorly. And then just another nice picture to show kind of the same thing that we've been talking about. The most important of these segmental thoracic branches is the artery of Adamkowitz. It's usually at the enlargement at the distal part of the cord. Usually it's from the left side 80% of the time. And it's usually the last couple segments of the thoracic spine. T9 to T12 is usually 70%, which means that it's not always there. And if you are doing a complete spinal angiogram to look for fistula, to look for pedicles of embolized tumors, then you have to identify this artery to know how is it coordinating its supply and is it safe to do this intervention or not, and to plan for how you're going to do your surgery. Is Ray on the line?
Yeah.
Ray, let's say you're doing a spinal cord tumor case and you see that the nerve root is totally involved in tumor and you have to take it so that you can ensure cure. However, you did not get a prior spinal angiogram and you're kind of at that lower thoracic level. Are there any adjuncts you can do in the operating room to determine if it's safe to take that nerve root, knowing that the Damkowitz might be traveling right there?
Yeah, you can, you have neuromonitoring, yeah, and you can put a temporary like clip or a tie onto that nerve root to tie it off and see if you have monitoring changes. If yes, then you probably tied off to a Damkowitz as well.
That's excellent. What monitoring would you be interested in?
Motor and SSEPs.
Excellent. Would EMG be helpful?
Wait, what?
EMG?
Not, I don't think so.
Probably not, because we don't usually monitor the thoracic nerve roots like we would
Right.
for cervical lumbar.
Yeah.
That's excellent. So you could put put like a string tie, occlude, and wait. And then if it's still stable and you are confident in your monitoring, then it might be safe to sacrifice. Okay. And then this is just a fun one to show for, thinking about anterior approaches to the spine and also thinking about spinal cord and spine perfusion. A couple of important vessels are the median sacral. This, as the name implies, median on sacrum, and it can supply fistula, and it supplies a lot of the neural and spinal elements of the lumbosacral region. Also, or let's see, Matt Carr, you're on the line?
Yes, sir.
Okay. Can you just take me through the big branches coming off aorta? So this is aorta here, right?
Yeah, so aorta bifurcates into the two iliac arteries.
Okay. Do they have another name? A more specific name?
I don't know what you're getting at.
Common iliac.
Common iliac.
Okay. And then iliac gives off.
Internal.
Okay.
And external.
Great. And then from the internal, you get another branch that comes out laterally on the sacrum. What is that artery called? And I'll pretend you're not reading it on the screen.
Is that the lateral sacral artery?
Excellent. And then there's also nice to show. So if you're doing anterior lumbar interbody fusion, Matt, if you do a L5-S1, looks like you probably have a lot of room, right? What happens at 4-5?
You start running into the bifurcation,
Bifurcation of what?
the common iliacs.
Artery or vein or both?
I think you hit vein first, but both.
Which one are you more worried about? If you injure?
I think the vein is more prone to injury.
Yeah, and harder to repair. So that's why it's helpful. And we always have vascular surgery assist with these approaches. And it's just another cartoon of that approach. And just another thing to point out, the superior hypogastric plexus also runs in here, autonomics. So with ALIF in a male, Matt, what are you worried about after the operation that they could have and that you counsel them about?
Sexual dysfunction.
Excellent. Retrograde ejaculation. The couple of angiograms just showing median sacral being canalized and showing all these sacral level branches it gives off. Also can give off this is lumbar actually, lumbar branches. And then finally, internal iliac, as you pointed out, Matt, gives off a lateral sacral artery. And in this case, this is not the case done here, but they had done a full spinal angiogram, could not find the fistula. And it wasn't until they imaged the left internal iliac, which if you're doing usually we puncture the groin from the right. So it's like the last thing, one of the hardest things to get into. They shot the left internal iliac and then they saw, boom, a fistula. So to be complete about your spinal angiogram workup, you always have to get the internal iliac. So I have a couple minutes. Just Dr. Chow, just let me know when you want me to stop. I just want to briefly go over spinal AVMs.
Perfect. Why don't you go until 7:50? That's when everyone else is joining. Thanks.
That's great. I think we can do it. So I was reading about this. Interestingly enough, the very first description of laminectomy for resection of a spinal arteriovenous malformation was done by Dr. Ellsberg, who founded our department and wrote it up. So it kind of brings us full circle here. This will be tested on your boards, some charts that you should be familiar with, and understand that there's multiple classification systems for spinal AVM, spinal AV fistulas. The most classic one is the ABF. It's like American, British, French classification. And they break it down to 4 types. I'll go through each of those. They each have their own kind of features. Dr. Spetzler further stratified this by taking out like tumor type vascular malformations, hemangioblastomia, cavernous malformation, making its own thing, and then separating the fistulas by ventral or dorsal, and in terms of AVMs, added a separate section for malformations of the conus. So type 1 is a true fistula. It's usually a single vessel. Classic story is like a middle-aged man who comes in with progressive myelopathy. It's usually in the dorsal aspect, usually lower thoracic, upper lumbar, usually one feeder. Usually does very well with embolization or surgery. And the etiology of its pathogenesis is from venous congestion. Usually does not hemorrhage, pretty low flow. Type 2, also called glomus. Think of this one more as an AVM, like an intracranial AVM of the spinal cord. Usually has a nidus, can have multiple feeders. Usually it is congenital. Usually the nidus is pretty compact and amenable to stage embolization with resection. Sometimes the nidus can be diffuse. And these like the AVMs of the brain, can hemorrhage, and they can have low flow, high flow states. Type 3, also known as metameric. Think of this one as just an AVM that involves all like embryologically, it involves all the somi parts of the spinal axis. So it involves bone, it involves dura, it could be intramedullary, it can be extramedullary, extradural, you name it. And these are incredibly difficult to treat. They take lots of stage embolizations. The surgical outcomes are not always as great as a nice fistula. So these require lots of multidisciplinary treatment. And then type 4, think of this one as an AVM that is supplied by the anterior spinal artery or the posterior spinal artery, as opposed to the radicular branches that come in. These are usually ventral, they usually have the anterior spinal artery, which makes them more challenging to treat. There's some people have separated them into multiple different categories based on the number of feeders, whether they come from posterior. These are usually low flow states. They don't hemorrhage that much. Similar etiology as the type 1s. So just to bring us home, I think I have 3 minutes. Dr. Malko took this patient for lambectomy. Here's a picture of the just engorged veins on the dorsal aspect of the cord. I think I can blast through this. So the ICG, you can see that all this, you can see the flow, whirling, violent circulation there. And then it was ligated. I'll show a quick clip of that. He found this fistula at the nerve root entry. You see that big dilated vein right there. Comes in with bipolar. Coag shrinks. Looks around. This is a picture showing the fistulous point that's been buzzed and cut. That's what it looks like after. And then on the follow-up ICG, he's looking around with his instrument. Don't see that abnormal swirling, no fistula. Close the dura, shot an angiogram a couple weeks later, same level. We no longer see the dilated veins that Halim had pointed out. And patient did well postoperatively, strength improved, ambulating, but still had urinary incontinence that required catheterization, which is from our SANS question. We knew that was not as likely to improve. So thanks everyone. I hope this was educational, and I'll turn it over to Dr. Chowdhury and Dr. Theodore to give us the rest of conference today.
Okay, thank you, Travis. I think we have both our guest speaker, Dr. Theodore, and our named lectureship people, the QBs, joining right around 7:50. So I'm just going to confirm that they're in, and then I'll start my remarks. So we'll just have a 30-second digital coffee break. Peter, can you confirm if you can see my screen?
I do.
Great. And can you confirm if you see if Dr. Theodore or the QBs have joined?
I don't see them in the panelist list, but I'm looking. Oh, I don't see any of them yet.
In case they're having technical issues, let's give them 1 minute or two more. I see Dr. Theodore joining. Good morning to Dr. Theodore.
Good morning.
We're giving a couple minutes for the David and Audrey Kuby to join, and then I'll start my remarks. But I'd like to thank you. You saved me from having to get a stress test. I called Dr. Theodore about 5 minutes ago saying, "Are you all set?" And he said, "Is it today?" So I passed my stress test.
Always got to keep you on your toes.
All right, Peter, I don't have a list of people who's joined. Can you just confirm if you see the Kubys?
Were they sent a panelist link or an attendee list? Do you know?
They're saying tuning in right now, and I believe it was a.
Oh, I see. I see now.
Yeah.
I'm gonna make them panelists so that if they want to say anything, they're welcome to. All right, I think we can go ahead.
Okay.
Can I just give one quick reminder? Everyone who's an attendee and not a panelist, if you'd like to ask a question, go ahead and type it into the QA box or raise your hand so that we can acknowledge you.
Okay. Good morning, everyone. And as everyone knows, this has been a very stormy year in global healthcare. And most definitely today is a sunny day, both literally here in New York, a glorious day, but also figuratively for our department and for our spine program. As we just heard with Dr. Ladner's spine conference, we definitely have a long history of spine here at Mount Sinai, going back to Charles Ellsberg and some of the early work. And the modern era has been equally strong with growing accomplishments. Today represents a very important sunny day for our spine program and the introduction of a special spine lectureship that through the gracious donations from David and Audrey Kuby, who I'll introduce in a minute. We have perhaps the best speaker I could think of to inaugurate this lecture, Dr. Theodore, and I'll say a few words about him. When I go back to my residency, which I started 26 years ago, one of my favorite things that I remember is the opportunity to have visiting professors come, giants in our field, to come and speak at both the Grand Rounds, which is a wonderful opportunity to hear them for an hour, provide a lecture on one area of their topic, but especially also the opportunity to get to know them as human beings. And that can sometimes be with a session with the residents afterwards, which we will do, as well as it can be with a dinner the night before, which unfortunately we will not be able to do due to the COVID pandemic. But we will hopefully in a future lectureship invite both the Kubys and Dr. Theodore so we can actually enjoy that connection when it's possible. The residents will be able to spend time with Dr. Theodore, and I really want to credit the department and all the people who lead this Grand Rounds for pushing ahead and allowing us to do this lectureship despite the challenges of technology and other things. Today, normally, as I said, we would have a beautiful dinner at a restaurant downtown, and we would all get to know each other. But since we don't have that opportunity the night before, I thought I'd do a quick, brief introduction of our three entities, the Mount Sinai Neurosurgery Spine Group, Dr. Theodore, of course, and a brief introduction for David and Audrey Kuby. Our department is led by Dr. Betterson, and to his credit, he's in his just over a decade, taken the department up to number 12 in the country in terms of neurology and neurosurgery. And this is a major leap and accomplishment, and we all share in that pride. It really goes back to Dr. Post, who established the department in a formal academics fashion, almost 3 decades ago. And the two of them are really the people that have built this. And there are a number of lectureships in several areas, but we have not had one in the spine arena. And today represents a very good new tradition. We also have great leaders who are vice chairs, and they're well-known, all internationally known surgeons. Our spine program is filled with right now 7 people, and I'm very proud of my incredible colleagues who are each in themselves leaders both locally and outside of in the country and internationally. We are losing Dr. Caridi later this year, and it's a good reason to lose him because he's being promoted to a major leadership post in Texas at a major program, and so we wish him well. I'm also very proud that we have a very diverse spine faculty here. We're one of only 6 in the country that have multiple female members, and they're active, very important. Dr. Zoe and Dr. Weiss, Dr. Rupert, Dr. Margettis, and Dr. Steinberger are unbelievable talents, and you'll be hearing more from them in the future years. So that's our spine program, and we are spread out all over the Mount Sinai campus, which has now 8 campuses or hospital sites and even more affiliations. A few words about David and Audrey Kuby, who, with their permission, I can say that they have both been connected to the institution in many ways, and I'll say a few words, as well as they have been patients of the institution, and I think feel a special connection to the neurosciences in general. And Audrey comes from a family, her father was a longtime trustee here at Mount Sinai. She and her family have been very connected with the Multiple Sclerosis Center, MS, and they've also been connected in other areas in the neurologic space, as well as now in recent years with our neurosurgery spine department. David and Audrey Kuby have been extremely generous to the institution with their time and dollars, and we thank them in advance for their allowing us to initiate this lectureship. And they are, I can say on a personal level, wonderful people, and my wife Nahar and I have gotten to know them, and they've introduced us to their golf club, which we subsequently joined in Sunningdale, and so it's a great honor to have them here, and I hope in future years to have a more personal, intimate setting to get to know them on a dinner the night before. And brings us to the main attraction for today, Dr. Nick Theodore, and I don't think anyone can be in neurosurgery and not know who he is, but I will do a brief introduction. Dr. Theodore and I have some shared lineage. He is someone who has come to neurosurgery with some training in the Naval Service, as well as at the Barrow Neurologic Institute, which has been a premier place to train and be a faculty member. He trained under the renowned, probably of our generation, leading neurosurgical spine surgeon, Volker Sonntag, who I did my fellowship with. And side note of interest, Dr. Post had a brief overlap with him at Tufts, and he was his chief resident under Dr. Post. So there's a lot of connections with our institution and Dr. Sonntag and the Barrow Neurologic Institute. Dr. Theodore quickly rose up and was able to ultimately succeed in the position of Dr. Sonntag in leading the spine service at the very busy Barrow Neurologic Institute until about 4 years ago, when he moved to the East Coast and took over the spine service at Johns Hopkins, where he's a professor of neurosurgery, orthopedics, biomedical engineering. And that doesn't begin to talk about his accomplishments. He has a probably 50 to 60 page CV. He has hundreds of publications. He has an H-index of 38, which puts him among the highest among spine faculty in the country, and certainly for his age. He is active in many areas of spine. He is going to be talking about one of his real areas of expertise in technology, the future of spine surgery, including robotics. He has many other areas of interest, including spinal cord injury and other areas he could talk about. On a side note, he has a very strong and deep experience in sports neurosurgery, which is sort of an evolving field that he and I and others have sort of been active in. And he also has recently published an article on the effect of COVID on Johns Hopkins spine neurosurgery. So there's many things he could talk about of interest for us. And we are happy he's chosen to talk about engineering the future of spine surgery. We are very grateful to the QBs for the opportunity to have this special lectureship experience. And we're also grateful for Dr. Theodore to making himself available afterwards to spend time with the residents to provide that kind of connection with, which is invaluable. So with that introduction, I'd like to turn it over to Dr. Theodore. Thank you again to the QBs and to Dr. Theodore for making himself available.
Perfect. All right, let's see here. All right. So, Tanvir, thank you very much for that very kind introduction. And to the QBs, thank you very much for sponsoring this. I think that, the sponsored lectureships are such an important part of neurosurgery, and I hope it's something that continues. The reality is that with so much information, we're an onslaught of information and everything we see and do, the face-to-face and now even via Zoom contact with people really is how we sort of spread knowledge, and especially in neurosurgery. It's still a field that, even though it's complicated, even though lots of things are going on, the reality is that having these opportunities like this are very important to me, to the residents. I learn every time we have a visiting professor come to Hopkins. I learn something and hope I can enlighten you a little bit today. The topic today is really engineering focused, neurosurgery and spine. When I was a resident, we were really all about biomechanics and making things right in the operating room. We've gotten so much better at that. The question now is, are there other technologies that we can use to help refine our art, to elevate the care that we provide our patients? And this is just going to be a glimpse of sort of where I think we're going. When we talk about, robotic surgery and what's happening in the future, people think about the movies. They think, well, there's some autonomous device that's going to perform surgery like in this movie Prometheus. And the reality is we're not there yet, and we're not going to be there for quite some time. And it's a little early in the morning to show you the whole clip, but the reality is that, this is far afield. So completely autonomous surgery is not going to happen for quite some time. Where we are right now is sort of enabling technologies, and we'll talk about that. These are my disclosures, and one of the devices I'll be talking about, the Excelsis GPS robot, is something I spent a long time of my life working on. We'll talk about how technology evolves as well. This is where we are in beautiful downtown Baltimore. On the left, you see the Traylor Research Building. On the right is the Zayed Tower. In the middle is sort of our iconic building. And in between those two is where I'm sitting right now in that green area, which is the Carnegie building. And on the 7th floor of the Carnegie building was really the original operating rooms at Johns Hopkins. This is where Dandy Cushing operated. And this is really where a substantial amount of the early work in neurosurgery happened. And it is now that same facility, which was the operating room right now, is turned into a biomedical engineering lab. So literally 100 feet from my office where I sit right now is this absolutely phenomenal, conglomeration of engineering entities that are commingled with surgery. So the Carnegie Center for Surgical Innovation is just that. It's a place where engineers and surgeons get together on a daily basis and try to advance our art. How do we make things better in the operating room utilizing engineering? It's become a very important part of my life. And the reality is that, we all have good ideas as surgeons. Putting those ideas into practice, that takes time, it takes effort, and it takes collaboration. And this, I think, is a great example of that. So when we talk about, technology, we all sort of get stuck in this rut after we finish our training that we're going to be doing things the way we learn. Tanvir doing things the way he learned from Dr. Sontag, be the same way. We get stuck in our old ways. These women here who were the telephone operators thought nothing can happen to them. Their job is safe. I mean, look at this. They have to connect every single call going through. But the reality is that things change, right? We've evolved. those operators of the past are something of the distant past, something we'll never see again. Now we're looking at not just the smartphones that we all have in our pockets, but things like drone phones, crazy things that are going to be happening. So the reality is that as the field advances, we have to be mindful of the past, but understand also that we're getting better at what we do. I think really the basis of everything in neurosurgery has to do with stereotaxis and really where we are in space in 3 dimensions. Victor Horsley really started this in the spine and the brain over 100 years ago, trying to make a device that would help us localize points within the brain and the spine. Co-mingled with that has been this technological advance when it comes to imaging. So obviously what we do is dependent on where things are. We can't operate on somebody if we don't know where the tumor is or know where the fracture is. And beginning with x-rays, that is, and all the way through MRI scan, you realize that these are Nobel Prize winning discoveries that have really advanced our field and taken us to the point where we are now, which is, from an imaging standpoint, is unprecedented what we can see. This is Watanabe in the 1980s looking at the stereotaxis and frame-based stereotaxy. It was revolutionary, and I will argue that this is probably the single biggest advance in our field in our lifetime, is the ability to, in 3-dimensional space. So for the residents who have grown up with this, you realize that when I was a resident and some of our guys with gray hair realized that we were doing surgery, we were opening up people's heads by putting our finger on their head where we thought the tumor was based on the MRI scan. And that was the way we did it. And it wasn't until this technology came out that really changed the world. And it's being used obviously now for every single brain case. We're not doing surgery without image guidance. Part of the drawback of image guidance though is a little bit of inattention, right? So the fact of the matter is that we have a sharp probe on the brain and everybody's head is turned the other way looking at the monitor. And we get distracted with our cell phones. And when we get distracted, we're not able to focus that technology, in all spheres. Things can happen. In the spine as well, utilizing image guidance, when that's has been around now too for over 20 years. Again, the reality is that this is from a series of upper thoracic percutaneous surgery that we did. This is over 10 years ago, 15 years ago. But the reality is the same thing applies. Again, we weren't really looking at the patient. What we're doing is looking at the monitor. And within that inattention, I think, got my attention is how do we do things better? How do we allow us to be more pinpointing what we do? So why is that important? In spine, why is it important? Why would you use image guidance? Well, what we're looking for is high accuracy and high precision. What we want is to be able to reproduce accuracy every time. Everybody wants that pedicle screw to go in perfectly, that lateral mass screw to go in perfectly, the odontoid screw to go in perfectly. And if we can use enhancing technologies, we can certainly raise our game. I think the numbers are sort of daunting when you look at how well we do with the placement of pedicle screws, which is one of our sort of go-to tasks in spine surgery and stabilizing the spine. We're nowhere near as good as we think we are. When you talk about conventional accuracy, which is freehand placement of screws, we're about 68% accurate. That is to say that a large portion of the time we're not hitting the mark. The good news is obviously that the majority of those errant screws, a little deviation, a little bit in the canal or out of the bone, they're not harmful. So that's good, but we're not anywhere near as good as we think we are. When we added fluoroscopy, we go up to 84%. And when you add 3D navigation in the form of intraoperative navigation, we go up to 95%. So this is interesting. These are based on large series, thousands and thousands of screws.
Have you ever worked with Dr. Francis? Oh yeah, he's okay.
Just okay?
Guess who just got reinstated? Well, not officially. Nervous?
Yeah.
Yeah, me too. Don't worry about it. We'll figure it out.
I'll see you in there.
So the real question, I asked this to my peers, and is okay good enough? Is it okay to say we're 68% accurate? Does a patient want to hear that? Does anybody want to hear that we're operating at a 68% accuracy rate? Even 84%, I would argue. So the reality is we can always do better. Having raised 2 boys, the mantra around the house was just that we can do better. And the fact of the matter is that when things happen, it takes one aberrant screw to ruin somebody's life, ruin your life and to wreak havoc. This is a case, of a misplaced pedicle screw causing paralysis. So what has happened? Why hasn't this become standard of care for us in spine surgery? Roger Hartle, published this very nice article about 7 years ago and showed only about 13% of cases were being done utilizing image guidance. And why is that? The reality is that a lot of surgeons at that time felt it was just too cumbersome. It just takes too much time. And we're all in a hurry. We all want to do another case. But we all should also want to be able to not just be faster at what we do, but be more accurate. But the reality is we've been slow to adopt. I would argue for Dr. Bennerson and the rest of my colleagues that we're sort of evolving. So the cranial surgeons, image guidance is used in every single case. We've been lagging behind. We're the guys with the compact 64 in our back. Our brain colleagues are the guys with the iPhone. We need to get that. We're in an unprecedented time right now when you look at the three fields of imaging, surgery, and robotics. So imaging and surgery, we've got that down now with image-guided surgery in the brain and the spine. Surgery and robotics, we've got that down, Da Vinci and other defining instruments. But we really now have this beautiful opportunity to take all three of these and put them together, imaging, surgery, and robotics. When you look at automation in surgery, this is a beautiful example from the Fyodorov Institute in 1980 in Russia. Why would you want to have to go to another operating room? So this is doing radiokeratotomy. The surgeon sits in one place, patients are all prepped, they rotate through, does the operation, next patient literally comes into him. When you looked at the outcomes, the fact is that he was, people are coming from all over the world. When you do things hundreds of times in a similar fashion and utilize all the technology, your outcomes are better. So this, doesn't exist anymore, but it was a pretty interesting example of trying to automate surgery. A lot of talk about robotics in medicine, and it really has gotten a lot of press and a lot of airtime. And the fact of the matter is that when you look, in the world, what's happening, this article came out a couple of years ago. These are the first 5 jobs robots we're going to take. Middle management, that's fantastic. If we have one less hospital administrator I have to deal with, that might be a good thing. Salespeople, now it's a sort of daunting, but we're not touching anything, especially in COVID, right? You're going in the store, you're checking yourself out, you're tapping with your money. So these, salespeople and cashiers going to the wayside. A lot of technical report writing is also now relegated to robotics and
We lost the audio for a second there.
Nick, can you hear us? We lost your audio. Peter, can you see if he can unmute him?
He is unmuted. I don't know why we're not hearing him. Can you call him?
Sorry. No worries, no worries. And Sophia. Hello.
Good morning.
We lost your audio. I don't know if there's something that's with your computer audio. If you can check that again, please. No, we can't hear you. I can only hear you from my phone. No. Do you want to just do you want to sign out and sign back in? Yeah. He's going to sign out and sign back in. I'm sorry for the technical.
All right, can you hear me?
Yes, thank you.
Yeah, I'm so sorry. I have no idea why that happened.
We missed the Jeopardy part, so right before that.
Yeah, so you didn't miss anything. I'll tell you that what I was talking about was the fact that, you know, as an oncologist or, you know, internal medicine doctor, there's no way you're able to assimilate all the data that is in the medical literature right now. And if you think about something like Watson Medical, the ability of the supercomputer to help. So if you've got a patient, 38-year-old woman from Phoenix who's got stage 2 breast cancer and has this genetic subtype, as an oncologist, it's impossible to assimilate all that information. So these decisions are going to be made, you know, largely with the help of computers, and that's going to change really the practice of cognitive medicine. Surgery, not so much, thankfully. So we look at medical robotics. Really, this is back in the 1980s. This is the Puma robot. This is a robot that was used to place a depth electrode. You see this woman seems quite happy. It's not scrubbed in. He's drilling a hole in her head. Those are different times. This is RoboDoc from the 1980s also. This came out of Johns Hopkins. This was really the first, you know, commercially available robot for coring the femoral shaft for hip replacements. Versions still being used today. In spine surgery, this is the first usage of a robot, and the ASOP device was used to hold an endoscope for thoracoscopic surgery. So back in the day, one of my mentors, Curtis Dickman, we were doing a lot of thoracoscopic surgery, and I would spend 8 hours in these cases holding the endoscope. By the end of the case, you know, my elbows were frozen in this position. I would go home. I couldn't move my arms. And we started using this robot, and I will be very happy to tell you that was the first casualty of robotics. People think they're going to lose their jobs. I was very happy not to have to hold the endoscope for 8 hours. But the reality is this very simple device didn't do anything more than hold the endoscope, and you wore a headset, and you could use it to make fine movements during surgery. But the nice thing was, again, it took the person out of the picture of having to hold the endoscope. When we look at this concept of operating from afar, the military has had a vested interest in being able to do surgery on patients in theater, overseas, in remote and austere environments. And that whole concept really became the Da Vinci robot. And that is a different type of robotic system. This is a master-slave system, but obviously one that is used every day. But the premise was originally for telerobotic surgery for the military. John Adler and the CyberKnife. Obviously, we've got a beautiful robot now for the delivery of radiation. This robot, the Artist robot, is very interesting. Tanvir called me. This is a hair replacement robot. And if you want to sign up, we got a number for that. But the reality is that we've got robots now doing everything. We've got robots for stereotactic depth electrodes. We've got robots for knee arthroplasty. And I will tell you right now, we'll come back to this in a little bit. When you look at knee arthroplasty, the fact of the matter is the orthopedic surgeon said, why? Why do I need a robot? Just like the spine surgeons. I can put pedicle screws in. I can jig a knee. I don't need a robot. So remember that, and we'll come back to that in a little bit. This is the newest robot. This is a robot that's used for endobronchial disease. So literally navigating through with image guidance, finding a small lesion, and looks like a video game with the joystick, but going through the bronchial tree and biopsying lung nodules. So this is really changing every single day the way we do things in medicine. So I don't want everybody to worry that they're going to be out of a job, because really the first thing that's going to happen is that robots will take away jobs that we don't want to do or that they can do better. And really we talk about these 4 Ds, the dull, the dirty, the dangerous, and the dear of robotics. And we're not, in spine surgery, we're not talking about true robots, true autonomous robots. What we're talking about are really cobots. These are devices that work alongside us. When you look at industry and you have a human paired with a machine that helps them do a task, your efficiency increases. Now, we don't want to increase our efficiency so much that we're just sitting around not doing anything. But the reality is that, utilizing this technology certainly can make us better at what we do. What we're looking for in spine surgery is this. This is a robotic arm that's programmed to throw a dart. You look at the left-hand corner, with each throw of that arm, the dart is at bullseye, right? We don't want anything more than putting in a perfect screw every time we put a screw in. And the reality is nobody's perfect. We try as hard as we can every day to do this, but we can actually definitely do better. The other analogy I like to use is NASCAR. When you look at NASCAR, this is from the 1960s, you know, car slows down, they're going to change the tire. Nobody's really in a hurry. They're doing a little body work here. Got a fender bender here back here. So let's go ahead and fix that while we're at it. We'll just kick that in. And, you know, things happen. They were fast, but certainly nowhere near as fast as they are today. When we look at spine surgery as it's done in an open fashion, you know, again, we're sort of relegated. We're looking at the anatomy in person. We're feeling the pedicle. You've got this giant incision. And you're putting the all in, you know, under direct visualization. And this is really the way we did things, the way I was taught, the way Tanvir was taught. We really were, you know, sort of taught this way of putting an instrumentation. When you look now at NASCAR, you can see that things have changed. So this is at 2016, and literally under 15 seconds, all 4 tires have changed, oil's changed, and things are ready to go. We've definitely gotten better at what we do. And we definitely can get better at what we do in surgery too. This is an MIS TLIF, literally 8 minutes, 4 screws. Simple as that. Why are we taking 20 minutes or 30 minutes or 45 minutes to do that when we can collapse the time of the procedure? That's just one aspect of what we do. When we talk about robotics and spine surgery, what we want is, certainly we're looking, you know, patients are asking for defining technology. We would like to reduce our radiation exposure to ourselves and to our patients. We want to be procedurally consistent, and we'd like to be able to plan sometimes of what we're doing. So when we get in there, we're not having to rethink everything. So almost 20 years ago, I prepared Volker Sontag's remarks as when he was honored guest at the CNS, and we talked about the future of spine surgery. This was my concept, you know, from almost 20 years ago of the first robot for spine surgery. Unfortunately, you know, there's a few things that get in the way of this type of paradigm, one of which is the FDA, which is not allowing any sort of autonomous surgery to happen yet. And, you know, our technology wasn't quite there. We talk about the reasons why we're looking at radiation exposure. The fact is that we are exposed to an inordinate amount of radiation. If you're using X-ray in surgery, you're getting a lot of radiation. And this has become really a public health issue, not just for our patients. They're having one operation, but certainly for the surgeons. We look at the increased cancer risk. In this one series in Italy, orthopedic surgeons had a 5 times increased risk of cancer. You know, spinal surgeons have a 10 to 12 times increase. Especially MIS surgeons, those who are using X-ray, less ray, whatever it is, there are a lot of ionizing radiation you're exposed to. And no matter, even if you are wearing lead and a shield, about 2/3 of that radiation still will get through. I'd like to get to the point where we're throwing our lead away. This is a real photograph of me throwing my lead away. They tested my lead here at Hopkins, and they actually came back to me and said, it doesn't work anymore. I was like, it's lead. What do you mean it doesn't work anymore? So I guess get them tested every couple of years because of little micro cracks, they lose their efficacy, but I'm done. I'm not wearing lead anymore, you know, with the usage of advanced imaging and robotics. So I started this project about 20 years ago of being able to target the pedicle utilizing robotics. You can see the robot there is the ASOP robot, the positioning device that Curtis used. I took it from the operating room, brought it into the lab, and you know, spent a lot of time thinking about, can we do this? And the whole issue was, could we use image guidance? So not just targeting the pedicle, but could we use image guidance to do that? This is on the left. There is Neil Crawford, who is my co-inventor of the Excelsius robot, and you know, we spent a lot of time together over the years. We still do, trying to refine these technologies. These are some early pictures of how things looked, you know, with this sort of Cartesian model at first. And then this is really what our first working robot was in Phoenix: 6 axes of rotation, basic linear control, and fully integrated to 3D imaging. And that was the key. You know, we had imaging in the brain. I said, why can't we use the same thing and automate that accuracy? And, you know, this is just holding a probe up and watching the early robot do what it was supposed to do, which was follow the probe. And again, you look at this, you're like, well, you're not bringing that into the operating room. And you're right, but it has to start somewhere. And this is really our early foray, first sort of image-guided robot. This is the special day where we literally, the first time we cannulated a pedicle utilizing a K-wire with the robot. Robot's in place. I'm putting a K-wire in. And, you know, really, this is 8 years ago, but the reality was it really was a phenomenal day because we showed that we could use image guidance, plan a trajectory, and then have the robot take us there. So that, for me, was the proof of concept 8 years ago that we can do this. And it's really not onerous. It doesn't need to be difficult. It's not brain surgery. The fact of the matter is that we can actually, you know, utilize robotics and advanced imaging in real time. So really, we came back to 2017, where we got FDA clearance for this device, and it has now become, you know, part of my armamentarium. I really am putting all my screws in, utilizing robotics, and slowly but surely, my colleagues here at Hopkins are adopting technology. When you look at the considerations for robots, there's a lot of questions you need to ask yourself. Where is the robot? Does it displace surgical personnel? Is it bulky? Is it attached to the bed? Is it on the ceiling? So there's a lot of questions. Obviously, from my standpoint, having a robot that comes in on wheels, does what you want it to do and wheels out is probably the most efficient. Things that are mounted to the bed or the room, unfortunately, you know, have to be there for the entire case. And that from a workflow perspective, that becomes an issue. One of the most important design considerations, I think, and for us as surgeons, obviously, is having feedback at every moment of where we are. So having that feedback, not just for the robotics for that part of the case, but understanding where we are, where critical structures are when we're doing tumor surgery, for instance, when we're doing other cases where we need to have an understanding of the anatomy, becomes critical. So this, again, we're talking about this intersection between robotics and imaging. Where does the robot fit? My residents are, well, you know, I don't want the robot in there. It's going to knock me out of it. No, it's up at the head of the table. We move it in. We want, and we're training our residents, you know, obviously on a daily basis, robotic surgery. One of the interesting things I've noticed is that the trays, the amount of equipment that we have out on the table is far less with robotics than it is with a traditional open case. You know, you want to be able to plan, and a lot of obviously everything else now is software. Being able to, you know, have things go to a reliable place. There are always error messages, but the reality is that this becomes a software driven solution. Now, once the hardware is built, the robot's built, really it's the software, which is the secret sauce that takes us to where we want to do. Workflow is a huge consideration, and this is where surgeons will say, well, you know, I'm fast, I can put in pedicle screws. Okay, if you can put pedicle screws in 8 minutes with only 2 x-rays, then you don't need a robot. But the reality is that, you know, for those of us who are mortal, the fact is that we do want to incorporate technology. We like technology, but we don't want it to slow us down. And you know, one of the issues is imaging. So just for an example, the paradigm that we designed was that you've got multiple imaging considerations. So you can actually have the robot navigate with 2 x-rays. So you can get an AP and a lateral x-ray here, as we see, draw where you want the screws to go, and the robot will go into that trajectory. You can use preoperative CT. You use preoperative CT, you get 2 or 3 x-rays to merge the CT to the patient at the time of surgery, then you're navigating, or you can use the O-arm or any sort of intraoperative imaging device that you may have. So 3 different workflows. Why does this come in handy? Well, it comes in handy. For instance, a few months ago, we had a case, get the CD of the pre-op CT is corrupted. I said, go ahead, get the O-arm. O-arm is out of commission. I said, what's wrong with the O-arm? The key that turns the O-arm on has broken in the thing. So there's actually a key, as if somebody's going to hijack it or carjack it. I guess we are in Baltimore. But the fact of the matter is the key broke in, no O-arm. What do we have? Plain fluoroscopy. Get 2 images, navigate off that. So you want to be able to have redundancy built in for the same reason. You also want to have feedback. So we all know the spine clamp when we use image guidance, but having an extra point, a surveillance marker, increases your accuracy and lets you know if something happens. What is our biggest fear in cranial or spine surgery is that somebody bumps this tracker. If that tracker moves, you're done. And if you're doing something percutaneously, you may not know if something moves. But having an extra point, reference point, gives you the ability to know if something changes. Having that image guidance, then also knowing if having feedback, if surveillance is off or if force is off, if something's deflecting because of increased force. These are all feedback mechanisms that you get during surgery. So this is the first case. This is October 4th, 2017. There's probably no less than 50 people in the operating room, my chairman, one of the deans, and everybody's sort of watching me. And this is Karina Zigorakis, who's my fella. And we're ready to put the first screw in. I push the button and I said, go to L4, and it goes to L5. And I said, okay. I push the button again. The robot go to L4, it goes to L5. At this point, beads of sweat are forming on my head, and I'm, feeling dyspeptic, and I'm realizing that I've spent 20 years on this project. I am now going to be the biggest laughing stock in neurosurgery, and I'll probably have to enter the, surgeon protection program and be sent off to Bolivia or somewhere, because the reality is that, people are going to look at me. And Karina says, what's wrong? We're at the wrong level. Well, it turns out we were exactly at the right level. Our incision was at the wrong level. So as we were getting the robot prep, Karina opened up an incision. We were a little off on the incision, and what we thought was L4 was really L5. Long story short, everything worked out fine. But those are about 3 or 4 minutes of sheer terror that I would not want to relive in anybody's lifetime. Planning is very easy. The interesting thing is, and this is what's been sort of neat, is that you can plan before the surgery. You can plan, a day before, the morning of surgery. We usually do it at breakfast. The morning of, we plan our cases for the day. But the nice thing is that when you're in surgery, if you decide that you want a more medial entry point so that you don't have to make the skin incision, you change it right then and there. So any sort of planning can be done on the fly. It's very intuitive. Bringing the robot in is easy. It takes literally 30 seconds to get it draped and bring it into the field. And then screw placement, for an MIS case, is really sort of cool, but have the robot go to the 4 points, drop a marking pen through, see where the trajectory of the screw is, connect the dots for the incisions like that, and make 2 incisions, and then go ahead and open the fascia and put your screws in. So literally, within the first 10 minutes, all the hardware's in. At that point, we can dock the retractor and do the MIS part of a TLIF, but we'll talk about the time and the learning curve. It really has changed the way I can now take a junior or mid-level resident through this case in an hour and a half, whereas the fact is that I gave up largely image guidance, 5-7 years ago, because it was just too hard to teach, too much fluoroscopy, et cetera. But now we're able to do this and to teach it in a reliable fashion. So other things, accoutrements, being able to have a retractor at the edge of the tip of the robot, being able to track inner bodies. This is now all part of what we do. So being able to see an inner body in real time, again, obviates the need for radiation exposure when we're putting in interbody devices. Having the robot arm, which can withstand about 180 pounds, hold a retractor for us has been great as well. This now lets us do things like single position lateral surgery, where you can do an XLIF or a lateral interbody and then put the screws in with the patient in the lateral position. If you've ever tried to do this freehand or with image guidance, you will never try it again, because it's just horribly painful. But with things set in, and not moving, you're able to do things like this now that we were unable to do before. This cuts down, instead of having to take somebody in a lateral position, put them prone to put the pedicle screws in, literally you're doing everything in one setting, significantly cutting down the length of your procedure. I want to show you a few cases now before we get on to some future stuff, but these are just a few cases over the last several months. This is a woman who comes in to the emergency room, one of our routine cases in Baltimore. IV drug user complaining of a bump on her back, and sure enough, she does have a bump on her back. She's got myelopathy, and again, being able to reliably put the screws in, guide yourself during the corpectomy, and again, doing this in a very rapid fashion. I'm going to spend a couple of minutes on this because this is sort of a fascinating topic, and digressing a little bit. But the reality is that this is a 19-year-old girl that we operated on last year with tethered cord. She had 6 detethering operations. She now presents with recurrent symptoms, horrible leg pain, urinary problems walking. This girl's in tears every day. 6 operations. You see the cord is on stretch here still. Again, what's our go-to for this? Our go-to is a 7th detethering operation. I can see everybody here. Raise your hand if you want to be the guy doing the 7th detethering operation on this young woman. No, nobody wants to do that. So one of the things I've become very interested in is spinal column shortening, and this is something now, we've published a series that just got accepted in neurosurgery, 20 patients who've had this, where we'll take out either T12 or L1, about 80%, so shortening the patient by about 24 millimeters to take the tension off the spinal cord. Because if you think of this problem, the problem is essentially that the spinal cord is under stretch. And by shortening the vertebral column, you take that stretch off. So we now have 20 patients at YT12. Well, you want to be below the last dentate ligament, so doing it up in the thoracic spine does not make any sense. L1, L2, L3, it's just too much work to do, and you don't need that much. So T12 is really the ideal body for resection, again, targeting about 24 millimeters of resection. Putting in pedicle screws before doing the partial vertebrectomy and then shortening the patient's vertebral column. This is the patient, and the resident calls me and says the day of surgery, goes, you know, Dr. Theodore, her pedicles are very small. I go, yeah, they all have small pedicles. He goes, no, they're really small. I go, yeah, no, I got it. I'm looking at those pedicles going, okay. Now, you know, if this is your freehand or even image guidance, this is a problem. But literally with a small burr, we're able to sort of tap in and expand the pedicle. And the reality is that, again, utilizing robot to help us with this, I think is a huge boon. This is the column, it's shortened. This is fascinating. So this is her spinal cord on the left prior to shortening. And you see the spinal cord, you see a little bit of excursion there. After shortening, look at the spinal cord. Once we take that tension off that spinal cord, it's no longer on stretch anymore. And you know, these patients do, by and large, do very well. Not everybody, but most patients do very well. And this is post-op. So this is our series of 20 patients. This will be coming out in neurosurgery soon, where we looked at improvement in bowel, bladder, back pain, leg pain, sensory. You know, these patients did well, very well. And interestingly, when you compare them to the cohort of patients who had revision detethering operation, they do better. So I think this may be a new way to think about this problem and a new potential treatment for this. When you look at Oswestry disability, significantly decreased disability scores in these patients across the board. And I think it's just going to be another way to think about things. This is another case, a 67-year-old with slip at 5'1". These can be difficult cases as well, especially trying to reduce high-grade spondy. You know, in an older patient, one issue is, do you need to reduce them? Can you fix them in situ? So this is a transvertebral screw across L5S1. Again, utilizing the robot gives us an opportunity to do things, PAR screws we've done, to do things that you wouldn't do open and that you can certainly do percutaneously. This is a patient from the other day, a man in his 50s, unstable fracture, ankylosing spondylitis, BMI 50, Jehovah's Witness. Because the last thing that you want to hear, BMI 50, Jehovah's Witness with this unstable fracture. Also had a pelvic fracture, pulmonary contusions. His preoperative hemoglobin was 7.6. And the anesthesiologist says, you know, if he loses any blood, he's going to die on the table because we just can't, you know, we can't give him anything. We're sort of maxed out on everything else. So this is the cell saver at the end of the case. 58 minutes later, post-operative hemoglobin 7.4, utilizing, you know, doing this percutaneously. So we have an opportunity again to change the paradigm in what we do. There's another case of a woman in multiple surgeries, cervicothoracic junction, kyphosis and instability. And again, utilizing the robot for those small upper thoracic pedicle screws. This is a case from just a few weeks ago, sort of a hybrid case. We're making an incision, don't go through the fascia, perk the screws, and then you can see here, decompress the spinal cord in a pathologic fracture for myeloma, put a cage in and get him stabilized with much less blood loss than normally we would have. This is a young woman, age of 12, who has a disruptive process, probably a burnt out infection. Everything's been negative. Again, being able to reconstruct her spine in a very short fashion, left the hospital 2 days after surgery. What has this done for us? This has really given us an unprecedented ability to assess our accuracy. So if you look at the way we plan our pedicle screws, we place them, we can get a report card. How did we do? Before, we'd use Gerstein and Robbins and say, is the screw in the pedicle? Yes. Is it a little bit out? Yes. But now we really are able to elevate our accuracy assessment because we know where we planned the screw and we know where the screw went. So why are these screws a little off here? Well, there's here, this one here, for instance, it's in the exact same trajectory, but lateral shift. A lot of that had to do with tip deflection of the drill. We've changed the drill paradigm and using a burr first. This has changed everything. But the reality is we now have a much higher standard to hold ourselves to because the accuracy now, we know what we planned, we can see what we placed, and we can see how we did at the end. So we just published this paper this year looking at three-dimensional accuracy, and the fact of the matter is that we now have a different way and a different paradigm of assessing accuracy where we can look to see exactly where the problems are. But again, this becomes less of an issue when things are exactly where we want them to be. Group spine Robbins becomes irrelevant because everything's in the bone. The question now is to a higher level, can we plan things from a biomechanical standpoint and use this sort of paradigm to look at accuracy and also improve our game biomechanically. And that gets us to this. So I told you before that the orthopedic surgeons say, well, why do we need, robot? I can jig a hip and a knee as good as anybody. Well, the fact of the matter is that now they are finding at several years out that their patients are doing better when the robot is used. They're having less of these mechanical access outliers and joint outliers, which are things that happen to an implant over time. When a robot is used, these things are far less common. What I will tell you with the robot in spine surgery is that not only are our screws more accurate, but I'm putting in bigger screws and longer screws. How many times are we in the operating room saying, give me a 5.5, 45 screw when you could put in a 6.5? So I think we're going to see our outcomes potentially change. We're also able to stay away from the adjacent facet. So already in the first few years, I've seen a decreased adjacent level disease because I'm not affecting that adjacent level facet. So time is going to tell. There's a learning curve with everything, and the Da Vinci folks have showed us this. There's a learning curve with robotic spine surgery, and you have to be able to do a few cases to get comfortable with it. What I will tell you is that you're still the surgeon, and this technology is not going to replace what we do. And while it may take some of the cognitive burden off of concentrating so heavily when we're putting a screw in, the reality is you still have to understand what's happening, how the technology works, and what to do if it fails. This was published last year. We looked at our comparison of freehand versus robotic assisted surgery, and we found that sort of over the course of the learning curve, obviously the MIS group had less blood loss, less length of stay, but the most important thing was that we decreased our time by about 4.5 minutes a case. So we started off at 3 hours plus in a case. We're now reliably doing the MIS cases 1 and 2 levels in less than 2 hours. That demonstrating that the learning curve is definitely attainable, and you definitely will get better. You just need to practice. For those of you who are my resident colleagues here, the reality is you're driving the bus here. All my residents are enamored with technology. They all have their iPhone. They have all got every little piece of technology, and they love this ability to bring this into the operating room. They're coming up with things I never even thought of. Last year, there was an article in the New York Times talking about master surgeons complaining about the fact that the residents of today aren't as skillful as the residents of the past. My mentor, Robert Spetzler, was quoted in the article, and he said, well, when I was a kid, I operated on squirrels, and that's how I got my operative skills. And by the way, all the squirrels lived after surgery. Of course, it's Spetzler, right? There was never a complication. Everybody did great. And, he said it was his usage of the hands, and he said that, the kids today are using their phones, and it's not the same thing. I would tend to disagree with that completely and say that as we evolve, it's a different paradigm. We're hopefully not going to be, clipping every aneurysm. We've got coiling. We're not going to be putting in every pedicle screw and shooting 700 x-rays. We're going to be using technology to make us better. There's, of course, a cost associated with that technology, and time is going to tell. But the reality is, if you can prevent a misplaced screw, if you can prevent that case I showed you earlier of an errant screw causing a spinal cord injury, if you've paid for the technology, it's paid for itself 100 times over. Why doesn't technology get adopted? Well, I told you this. If there's a workflow issue, nobody wants to pay for it, or if it slows us down, that's when it doesn't get adopted. So this really now at least in my hands and in those of in the hands of others, is becoming, you know, a reality, because we're now able to take a robot and marry it to other things, right? To do spine surgery, to utilize an O-arm or X-ray, MRI, etc. And not just do the mundane things, which is what we're doing now, but moving into other applications, trauma, tumor, you know, occipital cervical things, and then ultimately having a robot help us with tissue resection and bone resection. I think that's going to be coming down the pike as well. Cranial applications are here, FDA approval for a brain that we just got for biopsy and electrode placement. So the reality is this stuff is here. The last just few minutes, I want to talk about sort of other things that are happening in spine surgery that are engineering driven. This spinal line is a concept of measuring intraoperative curvature of the spine. When we're in surgery, doing scoliosis surgery, we don't have any real-time feedback of how our correction is. And that's a problem. If we position a patient on the table and we get some correction with positioning, that's great, but we don't know how much correction. So the real art of what we do in a lot of big open surgery is determining that. Utilizing technology with image guidance and other things, we are able now to take a preoperative image, assess where we are in surgery. And what we want to know is at the end of the case, we stand the patient up, how did we do? We can get that feedback in surgery. You don't have to be the one or two guys in the country that have this ability to make this happen, but we're going to be getting feedback now shortly in the operating where we can do this. And this is going to change things for surgery, because a lot of the scoliosis surgery I see migrating towards more MIS, where we can put screws in above and below, do a PSO, SPOs in the middle, and do a correction. But without feedback, that's not going to be possible. Soft tissue robotics are here. We've got an ability to, that's a robot sewing up a mucosa. I call this the dural tear robot. I'm waiting for it because unfortunately that still happens. Ultrasound is another technology we're looking at. Interestingly enough, ultrasound is very accurate, and it can be very helpful in the bone. It can be very helpful sort of for registration of the pedicle and getting updated registration. So we're looking at that as an adjunct to shooting additional x-rays. This is fascinating now. Imagine this. Imagine doing a spine case where you're registering a patient based on their MRI scan. So that we're working now with algorithms where we can take an MRI and backtrack and make it into a CT to get the data good enough to be able to navigate off an MRI scan and have it look like a CT scan. So I call this higher math, but the reality is these generative adversarial networks are here. We're working with them at Hopkins and the Advanced Physics Lab. This will be in an operating room. This is known component analysis. Interesting enough, when you get a CT scan, you have all this artifact. If the algorithm knows what the screw is, we already know what the screws are in that we put in. Look at the picture you can get by subtracting that artifact. So from an imaging perspective, we're raising our game as well, utilizing this known component analysis, being able to get beautiful pictures like this where you know exactly where you are and where the hardware is. Augmented reality is here. Augmetics and other companies now are coming up with this paradigm of being able to superimpose anatomy on a patient. I thought at first it was going to be only for teaching, but the reality is that in spine surgery, I think that there is definitely a role of being able to see sort of where we are, and again, taking away that inattention that we have of having to turn our head towards the screen all the time. So this is here. What about automatic pedicle screw placing? We just published this last year as well. The fact of the matter is, again, higher math, but easily done, utilizing sort of morphometric standardized bones. We can put them through the algorithm. The computer plans your screws. So one of the drawbacks, people say, well, I don't want to plan the pedicle screws. Okay, you're not going to have to. Soon enough, the computer will do it for you. As the surgeon, you're going to check the plan, make sure the screws are where you want them. But we can program them to say that surgeon A wants a more medial deviation, surgeon B likes a superior entry point. Or even better yet, how about utilizing biomechanical data to place the screws exactly where we want, having them line up so the rod fits, etc. So we're doing this right now, and also looking at this sort of global alignment. Is another project that we're working on. Device localization. Where's the tip of the device? Can we track that in real time? And the answer is yes. This is something else that has been an ongoing project. And then I think that the last foray for me is going to be artificial intelligence. We are now working on a very robust program where we're utilizing big imaging sets of patients over time, their patient demographics, patient-reported outcomes, and being able to say, okay, this is a 52-year-old woman. These are her images. What should the surgery be? Should it be an L2 to the pelvis, or should it be a T10 to the pelvis? Based on, on the history of what we've done, but also learning as we go forward. So I think we're going to get much better, because how many times are we planning a case and saying, yeah, I think you can stop at T10, and then we get PJK. So while some complications may not be preventable, I would argue that if we are utilizing large data sets like this to be able to help us in a predictive way, we're going to get to a much better place than we are right now. I think finally, a couple of things to consider. The first is safety. This is Admiral Hyman Rickover, who was the father of the nuclear Navy. And the reality is that from the ground up, he developed a nuclear Navy program where there has not been a nuclear accident in the history of the Navy. Stickler for safety and attention to detail. We have to embrace that. We have to make this technology safe. We know, though, unfortunately, unlike the nuclear Navy, things happen. This is us in surgery at Bayview Hospital last year. The intraoperative CT scanner broke while the patient's in the scanner. Sort of a unique problem. We're in the middle of a trauma case, and the patient's in the scanner, and the scanner's frozen. The bed's locked to the table, and one can't move without the other. So we're sitting there now troubleshooting of how do I get my patient out of this tube in the middle of an operation. So we really have to think about what can happen and how we avoid these problems. So this is one of the bigger picture items when it comes to safety in the operating room, especially as we use advanced technology. Surgical education, as I alluded to, my ethical responsibility is to my residents to train them to be spine surgeons, to train them to be excellent surgeons, and also to give them the enabling technologies to do that. And then ultimately, how do we assess our outcomes? So this is an evolving field, and while this technology has been adopted, while it's become a critical part of what we do, there is a learning curve, obviously. Different surgeons are going to do things a little bit differently. We have to look at these things, but ultimately, we're not going to go backwards. I think the trajectory is such that and the time is right now that we're going to move forward for this. So Tanvir, I see Kostas there as well. And to all my friends at Mount Sinai, I just dropped my younger son off at, that's him on the left, at Columbia. He's a sophomore at Columbia. So I was in New York City this weekend. I thought maybe I'd stay and have dinner with you guys at that nice restaurant. But alas, here I am back in Baltimore. I hope that we can all get together soon. But I sincerely thank Tanvir, Josh, Kostas, and all your faculty and residents for the opportunity to address you this morning, and certainly can answer any questions that you might have.
Thank you so much, Nick. We're going to open it up in just a minute, but I just want to say that that was a masterful lecture, as expected, and over-delivered even. And technology is changing our world. It's changing our world as spine surgeons. I often tell people that, as an academic spine surgeon, I have many jobs. I am a detective, trying to understand what's the patient's problem. I am a counselor, trying to help them decide what to do. I am a carpenter for the patients who need it. And we are also teachers. And each of those four roles, you've shown us some examples of how technology, whether it's with data, robots, or simulations or other things, can change it. And so, I think you've highlighted that there's needs for many things, including accuracy. There's needs for the cost effectiveness and all the other things. And, it should be efficient. And so in the past, image guidance was not so efficient. And we used to have, one of my colleagues had a joke saying, stealth stood for slowly touch everything and lose 2 hours. So, I think that, things you've shown us are making a difference in terms of becoming more efficient. And that's what surgeons want. We want what's best for our patients. We also want what's best for our careers and lifestyle. We can help more patients. And so my one question to you is, these technologies are very expensive, as you know. And just like our phones, every year or two, there's some new gadget we want to upgrade to. We sometimes run into that risk with these technologies. So how do you address that fact where a hospital you know, we tell them we must have this, it improves our outcome. And then 2 years later, there's a change. And how do you deal with the fact that we don't always get the $2 million budgets every 2 years, you know?
Yeah, no, and this is a great question, especially in the times of this pandemic when hospitals are in financial straits. The reality is that, you know, there are champions at each institution, you know, for technology. And I think that now that we've got FDA approval for the brain, for instance, for the Excelsis, just as an example, you know, you want to have to prove value across service lines. And, you know, to that point of things getting better, you know, things are going to get better incrementally. I don't see that every year or two there's going to be something completely brand new that's out there, but there will be things that probably are going to be added on. You know, again, the argument to the hospital has to be first and foremost patient safety. If you prevent 1 or 2 cases a year or a month or whatever of taking a patient back to replace hardware, that's already a cost savings. That's a risk mitigation. If you can do an extra case because you've collapsed the time of the procedure. So if an MIS TLIF is taking 4 hours and we can do that now in, you know, in an hour and a half, and we can do an extra case, there's an incremental value to the hospital there as well. And to the patients and to the system, because the patients are going home in a day as opposed to, you know, 2 and 3 days when we were doing things open. So.
I agree. MIS has proven itself, and many of us believe in it for that reason. So let's use our time. We have a large standing room only digital room here, and see if anyone has a pressing question. I know the residents will have a little time with you in a separate forum after this.
Yes.
Hey, Nick, Kostas here. What an amazing talk. I really enjoyed that, and thank you for joining us this morning.
My pleasure.
I think really hearing about your journey and your innovation and really resilience through something you believed and seeing it come to fruition is great for our residents. We try to teach them, you know, innovation and how to take an idea and take it all the way to the goal line into the end zone. And I think that's an important concept because we dabble in different things as neurosurgeons. And I think, you know, this is a great example of how you can take an idea all the way through. My question to you, Nick, is, you know, spine surgery, you know, when I trained at Pitt, a lot of it and everybody else at that time, it's all based on palpation and feel. And now we're kind of moving away from that paradigm. We're moving away to the image-guided trajectory approaches that are robotic assisted. And maybe some of that feel and palpation that we so relied on our spine surgery is kind of going away. And I just wanted to get your thoughts on that.
Sure, that's a great question, Kostas. I think 2 things. One, you still have a tactile feedback. Once the trajectory is locked, you can hear when the burr is touching bone, you can feel that feel, and you can feel when the pedicle screws go in, that really good feel that you have. I got to the point now where I can actually hear it. So the resident's putting the screw, you can hear that sort of squeaking as you're in bone. So you're still the surgeon, you're still doing the operation, and you're using this as enabling technology. Now, I think to the more important point I think you alluded to is that of education and how do we teach spine surgery now? And that's the more important point, because you and I and Tom Beer, we all learn to do things open, seeing, palpating, you know, and watching that screw go in. That I think is going to change. It changed a little bit with image guidance. It's going to change more with robotics. It does not supplant the need to have that anatomic knowledge. The residents have to understand that. We've got cadavers. We've got to be able to train and understand what happens. So just as an interesting point of this technology, Mike Lawton says to me, well, what happens if the robot breaks? You're screwed. The resident's not going to know how to put the screw in. I said, well, I said to him, you know, what happens if image guidance breaks when you're doing a cav mal in the brainstem of a 12-year-old girl? Are you going to just cut her brainstem open, or are you going to wait? He goes, well, no, of course not. So the reality is that, you know, we're going to become dependent. There'll be other redundancies built in, and the training is going to change. So my residents have to know, and we have enough guys still doing things open that they're learning. They have to understand how to do it. They have to understand what the bailout is going to be, et cetera. But going backwards and thinking that we have to open a segment of the population up and do a giant open procedure to teach the residents, that may not be because nobody's signing up for that anymore. Nobody wants that. But that's how we learn, because there wasn't anything better.
Awesome.
Wonderful. Do we have Any last question from the audience? Anyone wants to bring up anything?
I had a question, Dr. Theodore. Thank you for that talk. That was really incredible. So when you were talking about vertebral column shortening, I would love to know a little bit more about what your thoughts are on the durability of that treatment, because we all know that, you know, the re-scarring of tethered cords is a major issue, especially related to lipomyelos and things like that. And so I wondered whether you think that further adhesions and scarring could limit the durability of that treatment, just as our existing procedures are limited by it.
That's a great question. So, you know, here's the bottom line. The reality, in my mind at least, is that it's that chronic stretch that's the problem. We go down at the bottom to release those adhesions in a thought that we're going to make things less, you know, we're taking the scar tissue down and things aren't under stretch. When you look, Shoki Yamada did some beautiful studies in the 1980s where you stretch the spinal cord, and what happens is there's a lot of biochemical changes, a lot of, you know, bad things that happen as we stretch that structure. That's the problem. So the adhesions at the bottom are a byproduct of the original disease process, lipomyelin, and then our interventions. The whole issue is, if you think of it as the spinal cord as a rubber band around 12 building blocks, and it's taut, taking out that one building block and shortening that entire column, to me, is the physiologic way to address what I think the symptoms are secondary to. It's the stretch of the spinal cord. It's not the scar tissue, because this girl who had 6 operations now, you know, is a year out, back in school. She was dropping out of school. It's just, the pain was horrible. It's an end run around that problem. So I think, you know, the durability. Now I've got patients who are 10 years out, have not had to do one redo detethering on any of the patients who have the shortening. And every single person of the 20 in the series, we're now up to 25, I will tell you, when you ask them whether they would rather have a revision detethering operation or vertebral column shortening, which arguably is a much bigger operation, every single person said they'd rather have the shortening for whatever reason.
Okay, Nick, we have one question in the chat room, which is how would you deal with the problem that both reference markers move and you lose intraoperative navigation? How do you re-register, or what's the question?
Yeah, so because you've got the surveillance marker, you do have real-time feedback. The interesting thing is most of the time it's the tracker that's bumped. The tracker moves a little bit and it can click into another position. If that happens, you click it back into position. If you actually lose registration, it's not a big deal. You just get 2 more x-rays, an AP and lateral x-ray if you're using CT, to re-register. So the reality is that you definitely have an ability to re-register on the fly. And you have also an understanding if you lost your registration, because that's the most important thing.
Okay, so we've gone a little over, but I think it was well worth it, and we're going to let you stay on with the residents. I want to again thank you for making yourself available for this, and hopefully you will come for the dinner. You know, I will tell you, you have not sold me on the scalp robot, but I will take the dural repair robot any day. We had one for a metrics tube recently, and it would be great to have one that can get down there.
Yeah.
And I will I'll close by saying that I really want to re-acknowledge the QBs for their generosity in making this happen and being a partner in this educational initiative. And if David or Audrey want to say anything, we'd be happy to. Otherwise, we'll close it.
Yes.
Okay.
Well, thank you to the QBs for your support. It's a beautiful opportunity to share time with my colleagues, and it almost feels like I'm in New York City for a couple hours.
Okay, well, hopefully you will get a chance to meet in a future dinner, maybe next year's, okay?
You owe me a dinner time beer. I mean, you're not getting out of that.
All right, done. All right, thanks again. And we're going to close it from the official point of view and let the residents stay on to.
Do I just stay on, or there was another link?
You can use the separate link for the meeting with the residents.
Okay.
Right after we close this one.
Okay, got it. Thank you, everybody.
And I just want to also thank the department's administrators for putting this together, Peter Morgenstern and Tom Harmon from the Development Office for his support. Thanks again.